Dr. John Bennett broadcasting from sunny Miami today in the Neurosurgical TV online conference. This particular conference is about neurotrauma, and today we have the pleasure of having Dr. Kalsi-Ryan, a PhD from Toronto, Canada, University of Toronto. She's going to give a talk on a paper she did in the Journal of Neurotrauma, Responsiveness, Sensitivity, and Minimally Detected Difference of the Graded and Redefined Assessment of Strength, Sensibility, and Prehension. So, but first let me introduce the guest panelist, Simon Downs. Hello, Simon.
Hello, welcome. Thank you very much for welcoming me. I'm in Tokyo at the moment, and I'm looking forward to this presentation. Thank you very much.
You're welcome, Simon. And Dr. Kalsi-Ryan, could we see your face so we can introduce you, please? Just click on
Sure.
on the screen share and get off it, and then you can go back to it.
I see. Okay.
Yeah. Thank you, Doc, for taking the time. Good day. How are you today?
I'm doing very, very well, thanks. Thank you for inviting me to speak.
Yeah, this is I appreciate your courage in doing this. I know it's not new to you, and I know it's probably your day off, so we really appreciate it. So why don't you just basically tell us about yourself and what you do and what you're doing, and then how you got into doing your work, and then go into your presentation.
Certainly. So, as you already know, my name is Sukhvinder Kalsi-Ryan. I'm a clinician scientist at the Toronto Western Hospital in Toronto, Ontario, Canada. I am a physiotherapist by background, and the area of work that I do is really in the development of outcomes development. I work in a very active surgical spine program where I perform a large proportion of the assessments around patients that have spine surgery, and one of those areas is traumatic spinal cord injury. I've been the lead investigator on the development of a tool called the GRASSP, which is now being used worldwide in just about every SCI clinical trial that is out there, and we've been able to establish this tool to determine how much function and how much impairment changes after a traumatic spinal cord injury at the cervical level. So today I'll talk a little bit about this tool, the development of the tool, and how it's being used in research studies related to traumatic SCI and what it tells you.
Very good. Okay, could you lead us into your presentation, please?
Sure. Okay, so the title of my talk is Responsiveness, Sensitivity, and Minimally Detectable Difference of the Graded Redefined Assessment of Strength, Sensibility, and Prehension. The name of the tool is quite long, and we've acronymed it as the GRASSP, so I will refer to it as the GRASSP from this point forward. I'd like to acknowledge my investigative team, which include Dorcas Beaton from St. Michael's Hospital here in Toronto, Armin Kurt from Balgrist in Zurich, Milos Popovic from Toronto Rehab Center, Molly Verrier from Toronto Rehab Center, and Dr. Michael Failings, who is spine surgeon at my current institute. I'd also like to acknowledge the site investigators. This is a multi-center trial or study that we are presenting, and I'd like to acknowledge all the people that have been involved in allowing us or helping us perform this research. The GRASSP is an outcome assessment tool that we developed back in 2009, and we had a great deal of support in order to produce this tool. We have an international GRASSP research and design team that works together to continue to develop this tool. We have a number of institutes that have been involved in the development. Thomas Jefferson University, Uniclinic Balgrist, so Zurich, University of Zurich has been involved, the University of Toronto, and the University Health Network. We've had funding from a number of nonprofit organizations such as Dana and Christopher Reeve Foundation, Rick Hansen, the Craig Nielsen Foundation, and so on. And I just wanted to acknowledge the support around the development of this tool. So I'm going to give you a brief outline of the GRASSP. So basically, I'll get into more detail as to what the tool is. Basically, I'll talk a little bit about the GRASSP, the history of the measure, what it tells us about spinal cord injury, and how we can use this tool in our clinical, everyday clinical practices, but also in our clinical studies and clinical trials, what the importance of outcome assessments are and endpoint development in trial design, and how the GRASSP is being used in the field today. So we'll start by talking a little bit about what is the GRASSP and give you a little bit of a history about where this tool has come from. For those of you who may know a little bit about the history of spinal cord injury trials, back in 2006, the company Novartis in Basel, Switzerland, was about to embark on one of the first in-human clinical trials in probably 10 years at that time. The previous clinical trial that had failed prior to that was the Accorda Therapeutics trial. It would have been the first trial in a number of years, and they were going to undertake this clinical trial in the cervical spinal cord injured population. And at that time, what they recognized is although they were able to measure the benefits of these treatments in rats and rodents and primates as well, they were not able to look at how these treatments might be beneficial to humans. And so this launched the onset of development of new outcome measures for humans across the board. This became almost a global initiative where electrophysiology testing was being developed, upper limb assessments, walking assessments, etc. Anything that they could think that would be beneficial. If a treatment was beneficial to a patient, how would we determine efficacy? So they gathered a group of us. There were 6 of us involved from Chicago. We met in Chicago with funded by the Dana and Christopher Reeve Foundation, and we had representation from Vancouver and Toronto, Canada, Philadelphia, and Zurich. We came together as a team of 6 individuals, and we basically took a great deal of literature, already existing work out in the field, and we developed something called the GRASSP version 1.0. And as you can see in this picture, it isn't a very technical tool. In fact, it's very clinical. It's not meant to be technical because one of the biggest needs for the assessment was that it could be administered in an intensive care unit. And when you get into electrophysiology testing or any kind of measure that needs to be calibrated, there's a great deal of interference in an ICU. Therefore, this tool needed to be non-technical, feasible, available, and rigorously designed. So we designed this tool to be very specific. It is specifically for the upper limb and hand for patients that sustain a cervical traumatic spinal cord injury. So this is not necessarily a useful tool for people that have tumor compression at the cervical level, nor is it a sensitive tool for those people that are presenting to you with degenerative cervical myelopathy. The tool was also designed itself. Therapists can actually pick this tool up, pick up the manual, and teach themselves how to administer it. If the tool is being used in a study, it is recommended that some form of centralized or standard training is done in order to ensure that everybody involved in the study is doing the same methods. However, the tool can really be used by a clinician, and the clinician can teach themselves. What makes this tool unique is that we use a specific scaling and we've designed specific scaling and scoring aspects which really allow a person to numerically evaluate the patient. So what's in this tool? So the GRASSP consists of three domains: a construct of sensory motor upper limb function, which we then measure by performing sensory testing, strength testing, and what we call prehension testing. Prehension really means grip testing. So we look at the grip patterns of the hand to see how neurologically impaired an individual really is. The first part of the test is sensory. We look at the dorsal and the palmar surfaces of both hands, and we do this assessment with Sens-Weinstein monofilaments. So we get a dorsal sensation score and a palmar sensation score. We then conduct motor testing using a 0 to 5 scale for each muscle, and we look at 10 muscles in the arm. So this is what makes our tool much more sensitive than the international standards. We look at 5 muscles more than they do in the upper extremity motor score of the INSCI. And this is then scored out of 50 for each hand. We then look at prehension, where what we're looking to see is how well can an individual move their hand or move their digits, and can they actually produce certain and specific grip patterns. This tells us a great deal about motor function in the hand. And then after that's completed, we then do 6 tasks, or we assess 6 tasks. We have the patient perform 6 tasks, and we evaluate them to see how close to normal they're able to perform these tasks. Each one of these subtests, there's 5 subtests in the GRASSP, are performed for each hand. So you would basically have 5 scores for the right hand and 5 scores for the left hand. What you can see here is, I haven't gone into the details of how this tool is scored because I'd really like to talk about the measurement properties. But I've put up this slide for you to really get an understanding. So what we have here is a patient that is an Asia B patient that starts out with a motor level of C7. And as you can see on the international standards, this individual remains stable. They stay as C7 with respect to their motor level. If you look at the GRASSP scores, you actually see a slightly different profile of this patient. You can see that there's 3 lines. There's a baseline, a 3-month, and a 6-month line. You can see that the patient started out with fairly good sensation, and that would be expected, seeing that it's an Asia B patient. Their strength is not great, and they make very minimal gains in strength. However, what you do see is you see this very nice improvement in both qualitative and quantitative prehension. So you see that this patient begins to use their hand a little more functionally as they move out to 6 months post-injury. Despite the fact that their impairment is not indicative of this, you do see this improvement in function. And so this is where the GRASSP becomes a very useful tool. We are able to detect change that we don't necessarily see with existing tools, and particularly in this case, the current gold standard of measurement for spinal cord injury. We've done a great deal of work in the development of this tool, and that's in the area of psychometric properties, which is what I'm going to talk a little bit more about today. We've established the reliability and the validities of this tool through a cross-sectional study back in 2009, and we published this work in 2012 in Journal of Neurotrauma as well. Following that, we conducted a longitudinal study, and from that we established the standardized response means, which are essentially responsiveness and minimally detectable difference, which I'm going to talk about in a little more detail today. So what responsiveness is a psychometric property of a tool, and what it tells you is does your tool pick up change over time? So that's the first question we're answering. This is a very important question in clinical trials or spinal cord injury studies, because we want to know that if we apply a treatment, is the patient changing because of that treatment that we're applying? The other thing that responsiveness tells you, or the standardized response mean value tells you, is how sensitive is your tool. So is the GRASSP picking up more change than other tools that we are currently using? Minimally detectable difference is a measurement property that we can use to determine if there is a change in a score. For example, if the score changes by 2 on sensory testing, does that mean we are outside of any variability or what we might call error? And so I'll also present the minimally detectable difference scores to you. So what does the GRASSP actually tell us about spinal cord injury? So I have some recovery profiles here, and this is from our longitudinal study, and this basically shows you what you can tell about a patient's sensation using the international standards, which is the current gold standard. So this is using the INSKI light touch and pinprick. You can see that the patients do have some very slight improvements up to 3 months. However, they seem to look like they either have a reduction in sensation at some point or that they just plateau. If you look at the sensory testing that we do or perform with the GRASSP test, we see a very different profile. We actually see that patients have a fair bit of sensory recovery, which continues almost out to 1 year, and we see that for all 4 groups, Asia B, C, and D. If we look at motor testing, we see that the upper extremity motor score is quite effective in determining change over time. However, with the GRASSP, we detect even a little more change than the upper extremity motor score looks at, and I'll get into that when we look at our standardized response means. We can see that the measurement of some of the small muscles of the hand really do allow us to see recovery going on from anywhere from 6 to 12 months, which is greater than what we see in the upper extremity motor score. So I've separated the sample here into two groups. So we have our motor complete and our motor incomplete patients. And you can see that what you can see here, you may not be able to understand, but the lines basically show you specific groups. So I will just give you an example. The green line here at the bottom is a patient that might be an Asia B or an A that does not go on to convert from A. So they would remain quite stable. And as you can see, their hand strength does not improve. However, if we take that same type of patient, which is the orange line, these are patients that are Asia A or B that do eventually convert and become incomplete over time. They actually have a fair bit of recovery of strength in the hands. Again, we don't always get to detect this change with the international standards because we only look at two muscles in the hand. And similarly, in the Asia C and D groups, we see a fair bit of recovery of the hand going on all the way out to 1 year. So these are new findings. Typically, if you look at historical data of patients' upper limbs changing, we don't see a lot of change in the hand or the forearm with respect to motor recovery. We see a lot of improvement in shoulder recovery or biceps and triceps, but we don't see a lot of recovery of wrist flexors, extensors, or hand. And that's simply because the tools are not sensitive enough. So if we want to talk about responsiveness and sensitivity of the tool, this slide will essentially show you that. So the purple line is basically the GRASSP sensation testing. And what you can see is that the standardized response means for sensory testing are the largest or the highest. They exceed the red line, which is the Asia score. So what we're looking for here is we're looking for the larger value. If the value is larger here, that would mean your tool is more sensitive. So the larger the value, the more sensitive your tool. And you can see this also with the GRASSP strength, which is the lime green line just under the purple line. And this as well is a lot higher in general than the blue line, which is upper extremity motor score. So what we were able to show in this study is that in both motor complete and motor incomplete patients, the GRASSP tool typically shows to be more sensitive. So that's one element that we've established for this tool. So it's definitely more sensitive, and this is likely for some types of studies and depending on when you're performing that spinal cord injury study, a more superior tool to use. The minimally detectable difference. So what's minimally detectable difference? This is the calculation that one would perform to find that value. But what the minimally detectable difference really is it is the value that tells you that if you have a change above the values that are given on the right-hand side of this table, that is definitely a clinical change that you are detecting. So if I have a patient that I'm testing their sensation on the right side and they have a score of, for example, they have a score of 15 at baseline, and the second time I test them they have a score of 16, I cannot be sure that that's definitely a clinical change. I'm only certain that's a clinical change if that change in score exceeds 2 points. So if they start off with a 15 and they were to perhaps score a 16 or a 17, there's a confirmation that that change that's occurred is definitely clinical change. So that's what a minimally detectable difference is. And these are very, very valuable numbers when you start to look at your patient over time. So if I'm doing assessments at 1 month and 6 months and 12 months to determine how much my patient is changing, and I have somebody performing the GRASSP assessment, knowing that they have to change a minimum of 5 points before I know that it's a true clinical change is a very valuable piece of information, particularly if I want to know how my patient is doing. So that's where minimally detectable difference comes into play. So we've established these values now for the GRASSP, and that's what makes the GRASSP a little more useful. One of the areas we're currently using this tool in is how do we develop an endpoint, and how do we establish, if we are enrolling patients at baseline, so they're having a spinal cord injury, and we're enrolling them into a study, and we are applying a new treatment. Perhaps we're running a trial where we have a placebo group and a treatment group, and we're applying a new treatment. How do we know that placebo group is following what we might call a natural history curve, and how do we know that treatment group is perhaps having an effect from the treatment. So one of the aspects you must do before a trial is you really need to do what is called endpoint development. But it's really important that we've established these properties for this tool because it will help us in establishing therapeutic targets. So we now know what it would be, what it's expected of a patient that has a traumatic spinal cord injury that we watch over a year. We now know those values. Now, if we were to apply a treatment, we would know if that treatment's effective by how far away those new patients or those treated patients are away from that normal expected target. So a measure needs to be accurate with low variability. It needs to be sensitive to subtle change, and it also needs to be reliable between examiners. And we can now conclude that over the years we've established all of these values. So we use a technique called unbiased recursive partitioning. And this methodology allows us to determine that if we know what the motor strength is, or the strength of the muscles is at baseline, for example, somewhere between 0 and 10 days, that we can actually predict at 6 months' time what their prehension scores can be. So we've had an opportunity now to use this tool to establish whether we can use the GRASSP as a primary endpoint. And now what we're looking at, because of the robustness of the tool, we're seeing that we have a much lesser risk of ceiling effects. We're able to calculate sample size, and we're able to select a much broader range of patient for our studies because we have a more sensitive tool to apply. So I thought I might give you a real brief touch on how we're actually using the GRASSP in the field, particularly in spinal cord injury. And currently the GRASSP is being used in a few investigator-driven studies as well as industry-sponsored trials. And currently we're in study trial. The other industry-sponsored trials that are currently using the GRASSP right now as a secondary or an exploratory endpoint are the Stem Cells Inc. Asterias studies, which are both stem cell injections. Vertex phase 1, which is the application of a regenerative neuroprotective agent onto the dura, and the Neural Stem phase 2 trial for human neural stem cells. Currently, we have been able to market the GRASSP, and it is being used in 9 countries worldwide, and right now we probably have about 120 GRASSP kits out there that are being used either for clinical use or they're being used in trials. So in conclusion, the GRASSP is a standardized measure that distinguishes related levels of activity and impairment, and it is quite sensitive. Recovery profiles of the upper limb over the 1 year time course provide us with new insights for understanding history, sample stratification, as the next generation of spinal cord injury trials are focused on the cervical spinal cord injury group. The GRASSP will be useful in informing and defining study design and treatment protocols. The next steps are for us to establish the therapeutic targets and prediction on how to create these more inclusive protocols. And before I conclude, I would just like to acknowledge all of the funding agencies that have been involved in helping us get the GRASSP to this point. It is now a commercialized product, and we actually no longer require funding for it. It is a self-sustainable enterprise. And that would conclude my my presentation.
Well, thank you very much, Dr. Kalsi-Ryan. Excellent presentation. A lot of work went into that, obviously. And you can get off the screen share. Just click on the arrow again. I'd just like to comment a couple things, before we start into the discussion. Is that that's one area that's very dynamic, and as you know, in medicine, is the neuro-computer interface. And there's just a lot of work. And I think if you ask most doctors what areas of medicine would you like to see improvement, one of them is recovery of spinal cord problems. The other one is the early detection of occult cancers. So you're certainly doing work in an area that many people are interested in. It's well needed. And I'd like to introduce you to Slaven. He came late. He is a medical student from Croatia. Hello, Slaven.
Hello, my name is Slaven. Very nice to meet you. I'm a medical student in Zagreb, and I'm interested in neurosurgery and aspects of neurotrauma. Thanks.
Yeah, he's a future neurosurgeon. Okay, Simon and Slaven, would you like to ask the doctor some questions?
Well, yes. If I may ask a question first, I'm wondering what is your perspective now about the current treatment for spinal cord injuries? I mean, if you look at the whole picture, what do you think is the current state of the art?
So, with respect to spinal cord injury, if you're asking about drug trials, are you referring specifically to drug trial intervention or other types of interventions?
Well, specifically to other types.
To drug trials?
Yes, yes.
So we know a few things now. There are a few things that we know which are new. We've come a long way in the last 20 years. So we know that neuroprotective agents must be administered in less than 12 hours, if not sooner, and that most of the neuroprotective trials that have been conducted have actually been unsuccessful to date.
Mm-hmm.
So the field is starting to move towards regenerative opportunities, such as no-go antibody, the Cethrin drug, which is the Vertex trial, stem cell injections. What's really interesting to see is how far stem cell and Schwann cell injections have come. Because if you would have asked us 5 years ago, most people would have said it's very unsafe to inject stem cells into the spinal cord.
Right.
And what we now know is with the Schwann cell trial that's happened in Miami or ongoing in Miami, the Geron trial, the Asterias trial, and the Stem Cells Inc. trial, it's actually safe to inject the normal spinal cord with stem cells. So they're seeing that they're injecting the cord and that the patients are not getting any worse, that's for sure. They're also seeing very, I'm not sure if anyone saw the release of the safety study for the thoracic trial of Stem Cells Inc., but they're also seeing some very modest improvements in chronic patients in whom we'd expect to see no change at all. Mm-hmm. So what's really interesting is as the field's come a long way, we've gone actually beyond the drugs and into stem cell injections already, and people are seeing some benefit of those treatments, or at least opportunity to continue developing those types of treatments.
That's good. That's good to hear.
Mm-hmm. And perhaps another question, very shortly, if I can ask you, I saw that one of your supporters is the Christopher and Dana Reeve Foundation. So, can you comment, a person who would have a type of injury as Christopher Reeve had, how would he fare today? Is there any advancement in this field, or would he be in the same position?
So with respect to injuries that are such high-level injuries, I mean, I think his injury was C2, if I'm correct.
Yes.
There's very little that, other than phrenic pacers for the lungs and the diaphragm, there really is very little that has been developed to benefit patients with injuries that high level. The people that are benefiting the most from the research being done are patients that are probably at the C5, 6 level of injury and have some retained arm function, so maybe a little bit of shoulder and elbow function are the people that benefit the most from any intervention, whether that be drug trial, whether that be some type of a functional stimulation treatment. They are the ones that benefit the most. And also, there are a lot of rehab trials. So for chronic patients that are looking for, cuffs or hand stimulators or some of these techniques, there's quite a bit of that work that's very successful out there. They recently published the brain-machine interface out of Ohio State University, where they had the individual able to, use their brain to determine, through stimulators, to determine hand function. So those are probably more successful than the drug trials, those trials. So but no, there's not a lot we can do for the high-level quads at this point in the field.
Well, it's funny that you mentioned that, Doc, because today I posted a story about research being done on monkeys actually moving wheelchairs by their thought process. And this is a trial that's going on now. The monkeys are actually moving, just thinking about, somehow they structured the trial so they made the monkey want to move the wheelchair, and the monkey was successfully able to do it. So that's the area I believe you're talking about, correct?
Yeah, exactly. Brain-machine interface is called. And it's very popular right now with all kinds for walking, hand function, making an object come to you if you're disabled and you want to have your meal tray be wheeled over to you. So there's tremendous amount of work being done, and it's fascinating.
Yeah, it's a dynamic field. Simon, would you have a question for the doctor?
Yes, please. Thank you, Dr. Kalsi-Ryan, for your presentation. It's very interesting, and you mentioned that you have about 120 kits at the moment, and that the clinical trials are ongoing. And I wonder if you could give us an idea of how long it takes for your kits to go through the clinical process, the trial process, and then to be adopted into a system. How many years would that take, or for example, to the FDA, for example, or something like that?
Oh, that's a great question. So the way we did it was we didn't really go down a commercialization route. Our theory is to get as many people worldwide involved in the project to enhance our knowledge translation. So as you can see, we've been an international project all along. So this started out as a Europe, North America initiative. And that was one way that we believed that we'd really get the word, really get people to promote the use of the tool if it was a good tool. So we developed it, and once it was developed through publications, most of the work was done by the investigators around having centers use it. So, for example, in Canada, or being part of the Dana and Christopher Reeve Network, we're part of the North American Clinical Trials Network, which is 5 acute centers across North America. So that was an opportunity for us to use our own personal networks to say, here's a new tool we've developed. We should be using it in our clinical practices and our trials. So a lot of the uptake and the translation has been through our own personal efforts to have people use the tool. And that took a long time. It took a good 5 to 6 years. So by 2009, it was officially something that was available. We had started manufacturing it I had a small master student who had his own small biotech company do the manufacturing procedures for us, or go through that process. But it was Australia was probably the first country that wasn't involved, that was really interested in using the tool, and this was all through researchers. So there was no industry that was very interested in using the tool. It was mostly researchers just wanting to find something that would tell them more. And then 2 years ago is when industry finally came to us and said, we'd really like to try this assessment in a clinical trial.
Great. Thank you very much.
You're welcome.
Well, what company was that, Doc, that came to you?
So the first company, so interestingly enough, Novartis was the company that was involved in initiating this process.
Okay.
But then they fizzled out because I'm not sure if any of you are aware, but they decided not to proceed with the no-go antibody trial after doing the safety study. And so that fizzled out. And then Stem Cells Inc. came to us about 2 years ago, and that was our GRASSP. We set up our first licensing agreement with that company.
Are you're not involved actively in stem cell trials currently, are you?
Well, I don't do the stem cell. I'm currently at a hospital, or I'm currently at an institution, which is a big clinical trials center that is involved in 2 stem cells trials.
Oh, okay. Okay. Are you currently involved in another trial?
Okay, so there's 2 things. So where I work, in the institution where I work as a clinician scientist, yes, we're involved in 22 active clinical trials right now.
Oh, wow. Wow.
Now they vary. They're all spine related. 2 of them are stem cells, but then the rest are all drug.
Okay. Okay, well, I guess a lot of the stimulus for research in medicine, as you know, is drug companies. They've always been involved in research. That's nothing new.
Mhm.
But certainly, we'd like to. We're hopefully going to be developing an active spine surgery group. We hope to be able to interact with you in the future
Sure.
because I'm sure, what we're doing now. I call hangout publishing, where we talk to someone like yourself that has recently published a paper and is able to go online and in a live setting be able to discuss their recently published work in front of other people. And I think that's a wonderful thing, and I hope we see more of it.
I think it's a great idea.
Yeah, and so any way we can help you in the future with any of your 20 or more areas, just let us know. We'll be glad to put you on the internet and be glad to put you on with other people that you want to discuss maybe your findings of your work in the future. So the invitation's open to you.
Okay, thank you. I will be in touch then.
Okay, thank you very much for a great presentation, and hope to see you again.
Thank
Okay,
you.
thank you.
Thank you very
Okay,
much.
thank you.
Thank you for your time.